And the final presentation is from Barbara Laughton from South Africa, who will be giving us a presentation on deficits noted at 11 years in children with HIV starting early antiretroviral treatment in fine motor dexterity and auditory working memory.
Greetings from Cape Town, South Africa. We are grateful for the opportunity to present results from the CHER cohort at 11 years of age. The CHER trial, conducted at 2 sites in South Africa, compared early time-limited antiretroviral therapy in young asymptomatic infants who were perinatally infected with HIV. Infants were enrolled before 12 weeks of age, and those with CD4 percentages 25% or higher were randomized into 3 treatment strategies. The trial confirmed superiority of early time-limited ART over deferred continuous ART. Participants at the Cape Town site were co-enrolled on a longitudinal neurocognitive and neuroimaging study along with children who did not have HIV. We also included a subgroup of participants perinatally infected with HIV with CD4 counts less than 25%. This is a cross-sectional descriptive study of a longitudinal cohort. The CHER treatment arms of children perinatally infected with HIV were combined into one group. Children HIV exposed and uninfected, and children HIV unexposed were enrolled from similar neighborhoods as controls. We conducted a comprehensive neurocognitive battery at 11 years of age. ANOVAs were used to compare the neurocognitive scores of the groups, and means were adjusted for significant variables. Characteristics of 3 groups are presented in this table. There was a significant difference in gender, with less girls in this exposed uninfected group. The HIV group had a lower proportion of children with mothers as caregivers. We had an in-house caregiver stress measure, including exposure to violence and coping skills, and the feeling of having enough support, which did not show any difference between the groups. There was no difference in school grade distribution. The HIV-infected children were shorter than their counterparts. There was a significantly lower proportion of children whose test language was isiXhosa in the unexposed group. The children with HIV had started ART at a median of 9 weeks of age. 35% had ART interrupted at 40 weeks on study, and 19% were interrupted at 96 weeks on study. The median time that ART was interrupted in these participants was almost 35 weeks. Note that 77% were still on their original ART regimen started as infants, zidovudine, lamivudine, lopinavir, and ritonavir. At 11 years, the HIV group had a median CD4 percentage of 38.4 and an absolute count of 959. 21% had detectable HIV virus within 6 months of their neurocognitive assessments. These levels were low, with a median of 156 copies per mil, and the range was 22 to 1,841. 20% of the participants had previous diagnosis of HIV encephalopathy. On the neurocognitive battery, there was no difference between groups on visual motor integration tests, the Berry VMI or the Ray complex figure tests, or on the semantic fluency test. However, on the PER-JPEG board test, both hands, the children unexposed to HIV performed significantly better than those with HIV exposure. There was no difference between groups on the various domains of the Kaufman Assessment Battery for children after adjusting for important variables. Notice how the p-value for sequential processing, which is a measure of working memory, changed once we had adjusted for gender, test language, and mother as caregiver. The word order subtest contributes to working memory. And in this subtest, names of objects are first read to the child, who is then required to point to the pictures in the correct order once they are uncovered. Note the English words are all monosyllabic, and the isiXhosa words are much longer, making it harder for those children to remember the words. This can be a problem when comparing groups with different test language proportions, and also when describing results using standardized norms. I wanted to take time to share this example with you, as it forced us to change our title of our abstract and our findings. This early treatment cohort is actually doing very well, in contrast to other findings where children have global deficits, but most of them had not started antiretroviral therapy this early. Despite their early ART and careful clinical management, there are still persistent mild deficits in fine motor, speed, and dexterity tests, which was also described in a poster at 7 and 9 years of age cohort at this meeting. It is essential to adjust for important covariates. We plan to continue our exploration of these outcomes, including assessments for predictors and correlates of outcomes, including the neuroimaging and neural pathways that affect and control fine motor, speed, and dexterity tests. This study would not have been possible without many important role players and funders, and we would like to thank them all and acknowledge them.